All right. Good afternoon, everyone. Thank you so much for coming today. We have a very special event planned for this noon conference that we have here. I have a very special visitor, and I'm really excited that everyone's here. We have some pediatric colleagues here as well as transplant colleagues. It's really terrific to see everyone here. So Suzanne Watnick is our speaker, and the topic, as you can see, is the case for transformation. I think she's going to inspire us to lean in and actually make an impact on our patients. And impact, I think, is the one word that can describe what Suzanne has done in the nephrology world really perfectly. And she has done this through direct patient care at the VA, through education, both as a fellowship program director earlier in her career, but also now as a speaker at the board review course for American Society of Nephrology. And then as a leader as a chief medical officer at Northwest Kidney Centers from 2017 to 2023. That encompasses the pandemic. And I don't know how many of you remember when we were struggling during the pandemic to figure out how to take care of our patients. One of the very first podcasts that was done by the ASN actually featured Suzanne and some of the staff from Northwest Kidney Centers, and it was actually like a very clear explanation for what we should do in the management of dialysis. That was really very timely. And I think finally the other feature that distinguishes our speaker today is advocacy for our patients on a number of levels, both through quality of the care that we deliver, but also pushing legislators and pushing all of us to push our legislators to make a difference kind of in the care of our patients. So we're delighted to hear your presentation today, and we're very eager to be inspired to go advocate for our patients. Thanks again.
Thank you very much. Well, thank you very much, everybody, Tamara, and everyone who's really been wonderful in terms of hosting today. I think there's so much we can do, and I think it is true that we can make the case for transformation for our patients, and there are many people that I would say, they can't wait for this to happen. So really, there's no better example of an area that needs transformation than the way we treat end-stage kidney disease. We all know that there are 37 million Americans with kidney disease, and it's the 9th leading cause of death if you look at data from pre-pandemic. Primary form of treatment, dialysis. It's a part-time job that really very few people would apply for. Anybody need a part-time job? I don't think that you'd apply, even if you needed it. It's one of the most burdensome and blood-sucking long-term treatments that modern medicine has to offer. It's also far from optimal. I mean, really, 100,000 Americans starting dialysis every year, 1 in 5 are going to die in that first year. That's a worse prognosis than the average person getting diagnosed with lung cancer. The best option we have to offer is transplant. We've got, almost 100,000 people currently waiting and growing, as the transplant nephrology group knows out here, on the waiting list now. And so, let's think about really what we have right now as we start to think about the case we need to make. Modernization. I hope all of you have seen this picture once. If not, this is from the 1960s. Anybody know who's in this picture? So the gentleman laying down is the first chronic dialysis patient that ever existed. Okay, that's Clyde Shields in the 1960s. He was a Boeing machinist in Seattle, one of the first dialysis nurses in the middle, and that was Belding Scribner, who's the gentleman standing up there, who helped to co-create Northwest Kidney Centers, which was the first dialysis organization in the world. Lots of innovation back in the 60s. The thing sitting on the back, that's the dialyzer at that time, okay? Lots of modernization through the 70s. But I think all of you would recognize these that existed back in the 70s. Yeah, that is a dialyzer. Not a lot of innovation since then. And look at this. What is it? I think all of you would say, this is a dialysis machine. This is from the 1980s. It's what they looked like in the 90s and the 2000s. And last week, I went on eBay. You can buy one of these functioning on eBay right now and use it in your facility. And other countries are actively using this as technology. I'd like to contrast this with so many other places, but I just decided, this is a new slide I made, to bring up phones. You've got blue plastic rotary in the 1960s. And now we've got titanium with technology in it that can bring people to the moon and back. How far we've come. So what I would say is when you're in a field where literally 90% of your patients are funded by state and federal taxpayer dollars, we need to do better. The way that we can move forward is by getting some of those policy changes to make a difference. And so I do want to discuss for the rest of this conversation the last 4 years. There's been some movement in terms of policy and advocacy. So what did happen in 2019? Before 2019, kidney disease was common, it was increasing, deadly, expensive. Things were not well aligned, but nonetheless, it all existed. And what happened? A story happened. So who is this on the right? Anybody know who this is on the right? You can probably guess. That's Azar. So he was a cabinet member. He was the director of Health and Human Services with the last administration. And his father suffered from end-stage kidney disease. His father crashed into dialysis and ended up in a hemodialysis facility. His father was never educated about home dialysis, didn't really know what it was to get a transplant before he started dialysis. And his son was the Secretary of Health and Human Services, who was horrified when they learned that he could do this at home. He immediately switched to home because that was his patient, that was his preference, and then he got transplanted. And through this experience, he felt that if he didn't know about all these options, the rest of the country probably didn't either. And it was through his work that we actually passed and got signed the Advancing American Kidney Health Initiative, which this is a picture I took from the audience of this being signed by then President Trump. And it really is probably the most comprehensive governmental policy initiative since 1972, when everybody in this country, basically, if you had some work experience, could qualify for dialysis care, whether or not you're 65 years old. What did it say? Well, it said a few things. But what we'll focus on today more so are the second and the third aims. Yes, 80% of all new patients with kidney failure starting home dialysis or transplant is unrealistic. I actually helped author an article about the fact that even though it's unrealistic, it's great to try to move the conversation forward, and that's what it's done, and also doubling the number of kidneys available. So by way of that introduction, here are the objectives for today's talk. I want to describe recent national, and when I say recent, I mean really recent, like this year, national initiatives in transplantation. We'll also talk a little bit about some of the initiatives in the last couple years around home dialysis. I want to make sure we're all aware of the why. So if we're going to advocate for our patients, we need to tell our legislators, our regulators, or anybody out there why it is that we think we need to have higher rates, better care, and case for innovation for our patients. And then talk about the current policy and advocacy efforts to improve access for our patients, stuff that we in this room actually can consider doing. So lots happened. I love this. Breaking news, the U.S. plans to overhaul the organ transplant system, including breaking up the monopoly power of the nonprofit organization that runs it. Those are some big words that are pretty concerning indictments, really. That was in March. In May, Congress actually authorized an overhaul of the troubled transplant system, and bills were introduced. The bills from May were actually signed in a bicameral, bipartisan way, Senate and the House. By the end of July, bill to revamp the system goes to Biden's desk. And just 2 weeks ago, thank you so much for inviting me now, by the way, because it's so timely to have this conversation. This is Biden in the middle, obviously. Who's on the right? So we should know who this is. This is our cabinet member. This is Javier Becerra, head of Health and Human Services in this administration. And the tall gentleman next to Biden is Senator Wyden from the fair state of Oregon, who is also the chair of the Senate Finance Committee, a very powerful position, and also led this bill on transplant, which we'll talk about. Okay, so he's a huge advocate. Why do we need transformation? Why isn't everything okay as it is? Well, we know that transplant is the optimal treatment for most patients with end-stage kidney disease, okay? And I want to talk about some of the data just so we can remind ourselves about that. And although we transplanted the most kidneys in this country that we'd ever transplanted in 2022, we still have tremendous wait lists, terrible rates in terms of discard, and a lot of disparities in terms of our patients. 12 people with end-stage kidney disease or approaching end-stage kidney disease die each day waiting for a kidney on the wait lists. So let's just remind ourselves about the data. This came out from USRDS in 2022. It goes up until the end of 2020, just reminding ourselves about mortality with transplant versus mortality on dialysis. No, this is not matched for those that are on the wait list, but even if you're on a wait list, for example, on dialysis, you still have improved survival with a transplant. You can see that things went up in 2020. That was purely a result of the pandemic more than anything else. And that has started to level off according to people at USRDS. But it's not just mortality, okay? It's other things. And before we go into other things, I do want to remind you that, of course, it takes a little while. This is a classic article until you start to see the benefit of transplant. This is from Wolf in 1999 from the New England Journal. But after a few months, the risk of mortality with a transplant is improved versus dialysis, and survival becomes equal, as you can imagine, once you get to equal numbers of patients that have survived with both modalities. So other things, aside from mortality, it's not just mortality, but it's also with regards to hospitalizations. Transplant patients are going to have fewer hospitalizations. And they just started recording ER visits as well, which I think is an interesting graph from USRDS. This figure shows, of course, fewer visits to the ER on behalf of transplant patients, but also look in terms of the dialysis modalities. PD patients had fewer ER visits. Imagine that. Where's Vikram? I'm sure he's here somewhere. But we know, for example, not only do PD patients get seen sometimes outside of the ER environment, which is usually a good thing for them, there are also fewer visits overall, which makes you wonder about the benefit of various dialysis modalities. And the last thing I want to talk about in this slide is not just hard outcomes like hospitalizations and ER visits, but quality of life metrics. We also know that patients who have had transplants really do, on multiple measures of quality of life, do better. And this data is comparing patients who are on dialysis on the wait list versus people who have been transplanted. And this is a meta-analysis of exactly that. Nobody scores better in terms of quality of life scores if you're on dialysis. Some of the factors, it's hemodialysis versus transplant, about equal, but overall, transplant affords a better quality of life. So let's go to those three items, the wait lists, talk about disparities, and talk a little bit about discards. One more slide before we do that. It's also more cost effective if you get past that first initial period to do transplantation versus continuing on chronic maintenance dialysis. So getting back to those three items that we'll discuss in a little bit more detail, the wait lists, discards, and issues around disparities in our system, every 10 minutes another person is added to that wait list, okay? So even though you have people who are getting transplanted, that wait list is growing. So this is data from the beginning of the year, January 2023. You can see it's mostly people who are needing a kidney, not a surprise to us, okay? And of course, number of transplant performed by organ. The most are kidney, but you look at that 25,000+ versus the almost 90,000. And now what SRTR is saying is that it's well over 90,000 patients are waiting for a kidney. It is growing very rapidly. So an issue there. I think we really need to think about the discard rate in this country. How do we use the kidneys that become available? So before we go into the data about discard, like I said, 2022 was a record year, fantastic. You can see that donors continued to go up. In terms of living donors, you actually had that little drop off. We were talking about that when we had a conversation earlier today. Around the pandemic, people stopped being evaluated, for example, but that is starting to recover. And also with some of the changes in the system, you're seeing more deceased donors. So there are fewer people about to get living donors. But I would say over a 20% discard rate in 2020, that's 1 in 5 kidneys that are discarded. And in talking to some people who are working both at SRTR and who are on are leading some of the committees at UNOS, it's probably on the order of over 25% in this last year in terms of the discard rate. There are a lot of factors that go into that, but 1 in 4 kidneys are discarded. If you look at the EU consortium, Germany is a big part of that. That's 1 in 12 kidneys are discarded. So for every 12 kidneys, we had 2 kidneys that in Europe would have been transplanted, and it's not happening in the US. Again, a lot of things to discuss, but discard rates, we could get more people transplanted if we really pushed into that. It's hard to talk about declining offers for patients, but there's a median of 16 offers that are declined on behalf of each patient. And patients are not informed about that. It's hard to inform a patient when you have literally, a half hour to accept a kidney? So again, a lot of factors, but we need to think about what can we do better in this system. There are also a lot of disparities. Black patients are less likely than white patients to get a preemptive referral, to get their evaluation done, to get a living donor kidney. And the quality of the kidneys that white patients get, on average, they believe are higher quality than those that go into black patients. Rural and socioeconomically disadvantaged folks, they're less likely to be waitlisted or transplanted. It kind of makes sense when you've got, for example, where I am, you've got 4 programs right in the Seattle area, the 4th being the VA, but you get out in the peninsula, which is a little bit more remote, and those patients are not able to even get transportation to get evaluations. So there are a lot of social determinants of health that need to be considered as well. Women are less likely to be referred than men. So in this setting, there's been a lot of ongoing calls for reform. The Biden administration in particular has called for reform with a whole bunch of alphabet soup here. But we will talk about this in the next couple of slides. HRSA, the Health Resources and Services Administration, OPTN, Organ Procurement and Transplantation Network Modernization Initiative. So we're trying to implement crucial reforms to help more patients receive a transplant. And so that legislation that I showed you on that early slide, it really was passed by both the House and the Senate, support from both sides of the aisle, and this happened in 3 months. If you think about legislation that's introduced and then sits around on the Hill and passes, stuff to support transplant medications, for example. Do you know how long that took? Do you remember how long that took? More than a decade. So we're talking about, you need log paper to compare the amount of time that it took for this legislation versus a lot of other legislation in the kidney realm. So this is the Modernization Initiative. I know Sue Quaggan was a big advocate for this, along with the current ASN president, Michelle Josephson, that this was going to help to improve transparency and efficiency of the kidney health ecosystem. There's a lot that needs to be done, but the major goals that they want to be done for this modernization initiative include accountability, equity, and then performance, appropriate performance. What metrics should we be using? Should we be using 1-year outcomes, or should we be using wait list outcomes, or should we use something that's a little bit different than all of those to make sure that we're looking at things that incent programs to be transplanting as much as possible? It sounds like that's not a problem here at Northwestern, but there are a lot of programs around the country where it really is an issue. Technology. Do you know the technology that UNOS uses? Some of the platforms are still based on data from that uses DOS. It's not all in the cloud. Modernization is an issue. There was a governmental report that was just issued that specifically called out UNOS for not using modernized technology. Data transparency. UNOS, all of their funding has come from us, the taxpayers. They're not giving the government access to the programs that they're using. And in some of the reports that have been done, they're one of only 100+ groups that are contractors for the federal government that refuse to be transparent with their data. Governance. The board of the, UNOS is the contractor, which I'll show you on the next slide, for the government. The board of UNOS is the same as the governmental board for the OPTN. This is a huge problem. You're basically governing yourself. You're saying, hey, you're doing a great job. Great, I'm in charge of you. You're doing a great job. So again, there are a lot of issues around this, but there needs to be some separation between governance of the contractor and governance at the level of the government. And then just quality improvement. I mentioned a little earlier about quality metrics. Jay and I had a good conversation about different kinds of quality metrics. But we need things that are actionable and important for patients. So let's unpack this. It's a lot of alphabet soup. Like I said, OPTN, Organ Procurement and Transplantation Network, this is a division of HRSA. And what is HRSA? Health Resources and Services Administration. HRSA is a division of HHS. It's just good to know what the reporting structure is. A lot of people don't. UNOS, you always hear UNOS. That's the contractor for the OPTN, okay? But they're also the only group to have held the contract for 37 years since this was formed. And so people think of OPTN and UNOS synonymously a lot of the time. I mentioned the issue about the board, and you see this little inset here. This is worse than the compliment cascade, in my opinion, sometimes, just how the government is structured. But just want to remind all of you, HHS oversees things like HRSA and CMS. So you're talking about groups that are equivalent. So HRSA, in particular, you've got the OPTN, that is part of HRSA in the Department of Transplantation. You also have the SRTR, which is the Transplant Registry. So in the Department of Transplant, you've got the OPTN, and then you've got the registry group. And it's OPTN in particular that oversees UNOS, okay, which has the contract for everything. You've never had the contract for the data management and the technology broken up from who is keeping track of some of the metrics, for example. So I'm not going to go through this in any more detail, but I do want to give just a touch of history. So how did we get here? Congress actually passed the NOTA, National Organ Transplant Act, and that was back in '84. And in that, they said, we're going to establish a registry, and we're going to establish OPTN, and we're going to have contractors that we're going to award, and that was awarded, and that happened in '86. So it took a couple years, and they awarded it to UNOS, United Network of Organ Sharing. This left the U.S. government with a monitoring function to ensure that UNOS follows the statute rather than the type of usual oversight authority. And so with that is not very traditional relationship. And so things went forward. And the NOTA legislation specifically said for new contractors to come in, they need to have at least 3 years experience doing this stuff. Well, how do you bring somebody different from UNOS in here if you don't have any experience, unless they had experience in Europe or something? And you really haven't had people to be able to do that. So this is what this legislation and this modernization initiative is doing. It's aiming to break up the contract. In particular, the legislation said it had to be nonprofit. Now, nonprofit can be a very good thing, but you're also going to have a hard time getting new contractors to come in as nonprofits. Maybe there are some great people that are for-profits. For-profit or not-profit, whatever is best for our patients should come in. Let's bring in people who know how to do data analytics and technology at a level that's different from what UNOS is bringing. Maybe not, they can still compete for it, but let's have some competition. And then with the discard rates, how can we do better? So this was the initiative that we talked about. We really did need an act of Congress to change all of that NOTA legislation, and that's what these two bills, one on the Senate side and one on the House side, did. They basically said, we are seeing a system in need of repair. Our constituents, our people, our Americans are not getting access the way that they should be. So Senator Wyden, the gentleman who is the chair of the Finance Committee, who helped to lead this bill, actually asked for a report. In 2022, they had a hearing after they got this 66-page report back. And on this 66-page report, it was actually kind of scathing. It said that the organ procurement organizations really were underperforming. Some of them were underperforming. They said the system was really old, there were patient safety risks, and there was improper use of Medicare funds. And again, it's not by everybody, but there were some. So there's concerns. And this is where this legislation came in. Opening competition to the contract, giving HRSA, that reports to HHS, authority to improve management and then to support this modernization. So this bill really did get made into law very quickly. This was essential. I just like this slide from ASN saying, hey, this moved through very quickly. People went to the Hill and advocated, and they rattled chains, and they got people to say, please, please support this bill, and it happened very quickly. This was 10 days before the bill was passed. This is where I came in a little bit more of a assertive fashion. So it just so happens that Senator Wyden from the fair state of Oregon, where I was also there that day, things passed on the Senate side on the 28th. On August 3rd, he said, we're going to have a roundtable. And he invited the Secretary of Health and Human Services out to Oregon. And I got called, is there any way you can be in Portland on August 7th? And so there were only 5 physicians. And this is why it's so important to have voices at the table. I was the only person representing adults who had end-stage kidney disease who hadn't been transplanted. Everybody else, there were 3 people that were on the surgical side, and there was 1 person, a pediatric nephrologist from Seattle, who I'm sure you knew very well, a strong woman who advocates on a regular basis. So things have not been written yet. They asked us, what do you need? What do we want? Where should we focus our attention and our dollars? All the things I just mentioned, we talked about at that roundtable. And even though we in academic medicine might say, hey, we needed a study that was randomized and controlled, and we need several of them in order to say what the best treatment is, that's not always how things happen in the government. And I would say to you, for those of you who are interested in policy and advocacy, doing the right thing, at least based on the data that we know, can make a difference. They took notes. They fed it over to HRSA. The administrator for HRSA was there that day. Carol Johnson, the woman with the blonde hair at the right side of the table next to Becerra in the middle, that's her. So she is excited. She has called us back, all of the physicians that were there, to help have some conversation with their group as they move forward on what to focus on. Okay? So this is how we can make a difference, seriously. And it really can improve our patients. But again, the bill has yet to be written. I'm not going to go through all of this, but the bottom line is the government is trying to think really hard how to transition from one system to another. If there are new contractors brought in, that could really leave patients hanging. Patients could fall between the cracks between systems. So I'm just letting you know that they are thinking about this, but it's not perfect. You have a lot of smart people at HHS and HRSA, but they're not all transplant nephrologists. So feel free to talk and advocate about what should be done. Again, talking about timely, there was a blog post that came out from Jean Moody Williams and the government on September 15th, saying that we are establishing, as of October 1st, which obviously just happened, a new affinity group, Organ Transplant Affinity Group, which a lot of people don't even know about yet. They put out a strategic plan of action that should be in place from now until 2028. They want to address black box areas. The biggest concern of the HRSA administrator, the person in charge of this whole modernization initiative, is the issue of referral to wait list. So patients get referred, and then who's getting waitlisted? We have no data about that that's really good. Who's being left behind? Who's not being left behind? So if you have thoughts or ideas, write them down. Talk to me, because if I'm going to have a seat at that table, I'd love to speak on your behalf. I acknowledge the deep complexities here. There's no easy answer, but we have to invite all stakeholders, okay? So I'm not going to go through this whole slide, but the 2 aims of this new group with its 5-year strategic plan is issues around performance and issues around equity, okay? With the goals of reducing variation, increasing accountability for organ procurement and matching, and increasing availability and decreasing discard rates in terms of the performance, in terms of equity, equitable access, which includes not just thinking about wait list to transplant, but also referral to wait list and engaging people. So, okay, what can you do? Know your data. Who knows their data about Northwestern? I've talked to some people that know their data here. I'm sure all of you know something about what's going on at Northwestern, but what do you know about Chicago? What do you know about Illinois? And how do you do here versus other parts of the country? How have you done well versus other programs? And what are the things that make you special? And what are the things that other people are doing that make them special so we could do that throughout the country? Who are your legislators? Does everybody know who their legislators are? But more than who they are, what do they think about their issues? Do they think about it at all? Susan DelBene, who is she? She's a representative from the state of Washington. She is the congressional co-chair of the Kidney Caucus. Did you know there's a Kidney Caucus? Larry Bouchon is on the Republican side as the congressional co-chair. So there are people who really speak on behalf of us, advocate nationally too, not just locally. ASN, AST, I'm sorry I didn't have AST up here, I should have, and all kinds of other groups. Your voice really does matter. Okay, so I looked this up just like last week, and this is 2022 data. It's good for you to know your data and how you compare with some of the programs. I was like, wow, Northwestern transplanted over 300 patients in 2022. And then I think it was Vikram who said to me, no, we've already transplanted that many patients, more than that, just in 2023, and there's still all these months left. I'm like, really? That's amazing. Getting a deceased donor transplant faster than average. So on these bars, 1 to 5. 5 is fastest, 1 is slowest, but average is 3. So it sounds like it's about average, although it sounds like people are getting transplanted faster. This was 2022. And then 1-year kidney survival, 5. You get 5 out of 5 stars. So you do really well here at Northwestern. And look at the other programs. I mean, University of Illinois, 265 in 2022. That's a pretty large number too. And Rush and University of Chicago, 130 patients getting transplanted. That's a pretty large number. This all adds up to almost 900 patients. And if you are transplanting even more than that in 2023, and only 25,000 patients get transplanted in the country for the year, wow, Chicago itself is making up a huge percentage of who's getting transplanted. So it's good for you to know how you compare to other programs. And I hope that there's some kind of consortium so you can talk to your colleagues and see how you're doing well. What do these people know about kidney health? Anybody talk to Dick Durbin? When you go to DC, if you go to DC, do you go meet? You probably don't meet with him. But these people have health LAs, legislative administrators. They have their lead advocates that you would meet with, and you can ask for a visit locally or in DC. And all those groups, ASN, AST, they have days on the Hill where you can go and advocate for this. Tammy Duckworth. And then I just listed, I don't know the people who are your representatives, but you should know who they are. I mean, some of these people, 1997, Danny Davis, wow. But also you have somebody named Jonathan Jackson, who's just been since 2023. Maybe they want to look for what's important for their constituents, you know? Are there certain areas where kidney disease really, they have high rates of end-stage kidney disease in their district? Talk to people, advocate, know what they think about kidney care. I'll tell you, in Seattle, every one of our legislators, because I've talked to all of them, they know about Northwest Kidney Centers, which is the first dialysis organization in the world, because they like being proud of it, but they know how they feel about some of the issues around kidney care. I'm not going to go into this slide right now, but I'll summarize this section, and I'll go into the last section. There are some recent national initiatives to transform transplantation, and we just said that we have data to show clinical and financial benefits of kidney transplantation. Policy and advocacy are being created now, not just implemented, but created now. Be part of the conversation if you have interest. Don't be shy. Government can actually be effective sometimes in implementing change. It might feel like they're not, but there are a lot of good people trying to do good things. So knowing that there is so much to be done, and we hope that things go well, there are some arenas where there were policies that were changed a decade ago, and those policies did change what happened. And this took about 2/3 of our time. I want to talk about home dialysis for just a little bit to spend the last third, and then hopefully we'll have 5 minutes to talk a little bit. I really want to hear about, fifth row back, what you guys think about some of these bills and proposals, laws now, and everybody else too in the room. So I showed you the slide earlier. The middle goal was to increase patients receiving home dialysis as well as kidney transplantation. And there were a lot of things that went into effect in 2019, but there was stuff that happened even before that. This is a piece that is not even in print yet, but it is electronically available. I just put this out with some really cool people thinking about system-level strategies to improve home dialysis. So even though home dialysis rates in this country are going up, we are not at rates that other countries that have the modality freely available are at. For example, Canada is a very good example. So I would urge you, if you have interest in this, you can actually, it's still freely available on See Jason until it goes into print. So this just came out a couple weeks ago. So let's talk about home dialysis for just a little bit. So home dialysis, if you think about it, really go back for a ways, rates went down. And why was there an inflection point? So that inflection point is about 2008. There was legislation in 2008, and I'm going to show you that in the next slide. And then it looks like there's another inflection point around 2016. Well, there was a major dialysate PD fluid shortage, and people think that's the main reason, because not only could they not get fluid for their patients, they couldn't start new patients for literally like a year in a lot of markets. So there were some issues, but nonetheless, something happened between 2008 and 2016. Looking at rates of home dialysis, it's a little hard to tell here. Things continued to grow, kind of coming out of 2016 into 2017, to the point where there was 13.7% on home, where back in 2008, it was 6 to 7%, literally a doubling in the percentage of home dialysis. Pretty substantial. This inset is just showing you can actually read the y-axis a little bit better, that it really was 13.7%, the combination of PD and home hemo in this country. Major increase. So incentives, legislative and regulatory incentives. So in 72, as I mentioned before, was a very pivotal year for kidney disease because you had your Medicare entitlement for ESRD, and suddenly you were able to get coverage for home dialysis, in-center dialysis, any kind of dialysis, and 40% of patients were on home dialysis. I'm not going to go into the market forces that resulted in lots of in-center hemodialysis units springing up in places like shopping malls, but that's what happened, and numbers went down. Ironically, in 1983, we were down as low as 13.7%, which is where we are today. Well, at least we were 2 years ago. In 2008, legislation came through and said, you are spending way too much money in terms of fee-for-service for things like ESAs, and you're not giving good enough treatment to patients. So we're going to legislate that you're going to only get a bundle of payment for each treatment. And with getting only a bundle of payment for each treatment, suddenly the dialysis organizations were incented to do things that were less expensive so that they could maintain or grow their profit. That's how the for-profit market works. And so with that, home dialysis was less expensive. And starting in 2008, that is exactly why home dialysis grew. There was lots of pushes. With that legislation, the bundle didn't happen until 2011, but everybody knew it was coming. So that's why there was a push to increase. And you improved incentives to use the best value dialysis modality, knowing that mortality in the first several years, probably not that different for PD versus home hemo if you really dig into it, but quality of life probably is better for patients receiving home dialysis, for others on in-center who would qualify for home dialysis, which should be almost everybody, but isn't always the case. So one question for all of you in the audience, for those of you who see patients who may be thinking about end-stage kidney disease treatments, when you sit with your patients, do you ask them, do you want to do dialysis at home or do you want to go travel somewhere? Well, if you actually ask patients, depending on the group, probably somewhere between 25 to 50% of patients say, I want to stay home. It's not everybody, but it's a lot more than what we're doing today. Can you really do that? Can we get there? It's not easy. Well, the best programs in this country actually are at the 20% in terms of growing and growing. We actually really pushed. We were at 12% back in 2016, and we now at Northwest Kidney Centers are at 20%. We're there. Satellite is also at about that rate. And there are certain pockets around the country where you do, also more rural communities like in Alaska, for example, where you do have higher rates of home. It's hard to get higher, but certainly 20% is a lot more than 13.7. So why home dialysis? I mentioned about the mortality. So these graphs look very different, but if you look at the hemodialysis patients that do say that they could do home dialysis, it's probably relatively equivalent, maybe a little bit better. But I will say that if you look at all of the literature about quality of life, PD patients on all the different metrics, the SF36, the KDQOL, or the different components of those two, on average, it's either the same or home PD, not home hemo, because we don't have enough data for home hemo. PD wins out. I think this is a really interesting slide, though. You take patients on PD, all the patients on PD, and follow them over 2 years. What happens? It's hard to maintain a very robust PD population because a lot of them get transplanted, a lot more so than the average in-center hemodialysis population, and a lot of them convert to in-center hemodialysis. Of course, you have a lot of mortality as well. So it's really hard to maintain that population. You have to do hard work, which I know you've been doing at Northwestern as you've grown. This just shows you how much hard work the home program has done in order to maintain their population. Rates have increased in all racial and ethnic groups, but there are still disparities that exist. There's a lot of literature that's being written about that, but that is true. What has the government done about this? There was a report that came out in 2015 that says we really can increase, which in 2015 we continue to do. Of course, the pandemic drove some of that too. And you saw the 13.7% from USRDS in 2022, that was based on 2020. Probably we're around 15% as a country now, in part because the pandemic is what it is, did what it did. Physician payment discouraged PD to some degree. That's being changed as well. Recognizing these things helps to drive policy changes that can help change outcomes for patients. There are other things we did. Telehealth. Who did telehealth before 2020? Okay, so in April of 2020, March 2020, we had 0 telehealth. By April 30th of 2020, we had telehealth capabilities stood up in every single one of our dialysis facilities, and most of our physicians had done at least a couple of telehealth visits with our patients bedside. We bought iPads and stands, and the nurses brought them to the patients. Simple things that unless we had pushes to do, weren't going to be able to be done. And why could we do it? Well, if doctors weren't going to get paid for it, do you think that we were going to be doing that? No. It was the policy that changed during the pandemic that allowed for that to happen. Because it stood up and because of legislation and policy change that had happened in 2019 for home only, and we had the capability to do telehealth, after the public health emergency retired in May, we were able to continue to do all this telehealth because there was legislation to do so. And so patients are getting served. They're not having to drive into facilities to the same degree. You can do your physician visits 2 out of every 3 in a quarter, every 3 months, from home and be able to bill for that. Other fixes. So the Advancing American Kidney Health Initiative that I mentioned really wanted to encourage home and transplant. Who knows about the ETC, the ESRD Treatment Choices Program? If you don't know about it, you should. It is a mandatory program that provides financial penalties or bonuses for higher rates of home dialysis and transplant. 30% of all dialysis organizations and 30% of all nephrology practices in this country were randomized to this model. Is it in Chicago? Who knows? No. Rockford? Where else? There are two other. So I actually looked this up for where it was in Illinois, because it's supposed to be 30% of each state, and I'm going to switch to that. So do you know if you're participating, and do you know your home and dialysis treatment rates? I'll go back to the other slides in just a moment. So Evanston, Peoria, and Rockford all got randomized. Thank you. So it's good to know this, because those programs are being incented to have higher rates of home and higher rates of transplant, and they get paid more or get paid less. And you get paid more and more over time between now and 2027, depending on what your rates are. When you get out to the 2027 time period, based on 2025 data, you can have up to a 10% penalty. If you're making a 2% margin, that means that you have lost more than you're making, and you become an unviable business model, and you will not be supported to do that. So I think it's really important to be aware of these models. And this model, where only 30% of the country is randomized, is being looked at very closely by Medicare. The Innovation Center in Medicare is doing this, because in 2027, they're probably going to move forward with a model, and everyone thinks that it's going to look like this for 100%. All of your patients, okay? All the more importance for doing the right thing for transplant. The scores are 2/3 of the score are based on home dialysis and 1/3 on transplant. So you say, what can a dialysis organization do about transplant? Well, we're going to learn. We're going to learn. Forming partnerships, working with the transplant nephrologists and the surgeons, making sure our patients are referred and having spaces, maybe the social worker, for example, the dialysis organization. That's how we do it, and make sure that every one of our patients are aware of what's going on. So this ETC model, there are supposedly preliminary successes. They're saying that in the ESRD facilities that the home dialysis rates are almost 20%. Well, there's some gaming of the system when not everybody is randomized. So some of the dialysis organizations are moving patients into the areas that are right on borderline into the models. So the numbers look better. And the places where there's not this model, lower home numbers, there's no penalty. So be careful about data that you see, and the transplant rates are quite high as well. So I showed this slide a little bit earlier. 46% of the ESRD facilities and more than half of the managing clinicians are eligible for all this payment, okay? And at least the first couple of years, it looks like it's not, this program is not designed to be cost neutral. The first couple of years, the managing clinicians actually do a little bit better. It's gonna be year 3, 4, 5, where we start to see the managing clinicians doing worse. Do you see any patients? Do you see dialysis patients in Peoria or Rockford, or is that a different group? Different group, okay. So it won't affect you now. Medicare sees this as a huge success. They see it as driving up home and transplant rates. We've really got to advocate and talk to them to show them how the system is being gamed to some degree. They see it as saving money to the government. And so the future model design is underway now. This is why advocacy is so important. What else about home? Well, a lot of other countries have set quotas, for example. Fistula first drove fistula rates. So if we say you need to be somewhere between 20 to 40% of home, well, we'll see what happens in terms of quotas. It probably won't really take place that way in this country, but people are thinking about it. You think about different systems. Hong Kong is PD first unless medically contraindicated. What are the rates of PD in Hong Kong? They are well north of 50%. We're talking 70%. Thailand recently in the 2008 periods changed their policy, and their rates of home have also gone up substantially. Canada has higher rates, and China has actually implemented stuff. That hasn't changed as much in China, but it has nonetheless. So one of my last slides, this is the summary for the whole talk. There are recent national initiatives, as I mentioned, both for transplant and home dialysis. There's a lot of data to show the benefits of these modalities. You know, yes, there's obviously a place for in-center hemodialysis for end-stage kidney disease. Don't get me wrong. But probably we should be having more patients on home dialysis and more patients getting transplanted to make sure that we're doing the best we can. Advocacy now is going to make a difference. Government change can happen. It really can. I want to really thank all of, not just you here, but the whole kidney community for supporting all of these efforts. I want to thank Northwest Kidney Centers, which has really been amazing and mind-blowing for me to see how things work on the administrative side over the last several years and how the system works to try to best benefit patient care. We are a nonprofit dialysis organization, and profit or not profit status, I've met lots of people over the last 7 years who really care about patients at every dialysis organization. The LDOs who are for-profit need to be part of these conversations too, because they care for 80% of the patients in this country with end-stage kidney disease. UW, VA, all of our advocacy groups, and every one of you for your interest. So I just want to say thanks, and I really hope we can maybe ask some questions I can try to answer for you, and I'm always available, especially for people who are interested in advocacy. Thank you so much. Thoughts? Oh, thanks.
You didn't talk much about the kidney care models and for Medicare patients and how that's working. And I wonder if you have a perspective on that. We've seen some examples where it's been successful and not. And I just wonder what your take is on that and how it's spread to.
Well, let me tell you, the ETC is one of them. So there's the mandatory ones. There's the voluntary models. So Kidney Care First, which was led by nephrologists. I shouldn't say this out loud, but it's pretty much uniformly been felt to not be very successful. Because nephrologists as an entity, if they're in systems, the systems could not participate. Most of them couldn't for a lot of reasons. They didn't have tax ID numbers that could be separated out. I know that sounds silly, but literally you couldn't participate if you didn't have a separate TIN. If you didn't have a system that was excited to support you and provide resources for the nephrology group to not participate. So all these nephrology practices were super interested initially. Nothing. Really. That's going to go to the wayside. It's unfortunate because then you're going to not have nephrologists leading here. If you look at the CKCCs, which has probably been a lot more successful because you do have primarily dialysis organizations or other kidney care entities helping to support with nephrology groups, with transplant folks, to try to think about participating in larger ways to drive the bus for CKD, end-stage kidney disease, on hemodialysis, end-stage kidney disease with transplantation as well, and to look at it as unsiloed care. So you're trying to make sure you're lining things up for best incentives. The data's still out on that, but there are enough participants that we will have the data. The beginning data for that, as opposed to the ETC, which we already are seeing, is probably going to not be able to be really well analyzed for another year or two, but I'll tell you that stay tuned. We'll see. If it's financially successful, I'm telling you, it is going to take off if they allow for next stage. So there were 2 waves that you could participate. That's done. When the next stage of kidney models come out, which will probably be 2027, proposed in 2026, 2027, to be implemented the following year, it really, I hate to say it, depends on the dollar. If it's financially viable, hopefully it also did better for patients, then it'll probably be moved forward into the future models. And really, Medicare would do that. These are all for Medicare fee-for-service patients, which is a lower and lower proportion of all of our patients. So it used to be 80% of all patients were Medicare fee-for-service patients, with about a little under 10% on Medicaid only and a little more than 10% commercial. Medicare Advantage came into the scene in a big way in 2021. Even before that, it was there a little bit. And that has eroded fee-for-service, which is a whole different conversation, a different lecture. But now we're at about 50%, a little less than 50%. It's going to get less and less. So it's going to be a smaller and smaller proportion of patients that are going to be able to take benefit. But I do think that there's going to be a lot that we see as the data comes out. But what I will say is these new models, ETC is being seen already as a huge success. So you probably will see whatever the new model is, they're going to incent home and transplant. That's my guess. That is not me speaking on behalf of anybody but myself, okay? Great question. There was somebody else who had a question. Tamara.
Yeah, thanks very much. That was really terrific.
Thanks.
I was wondering if you could put on your program director
Oh.
hat and comment on the education on home dialysis and general nephrology. What should change about that?
Yeah. So having spent more than a decade as a program director and being very invested still in education of fellows, I do think we have opportunity to do a better job educating our fellows on the home dialysis modalities. PD for sure, but even more so on home hemodialysis. It's hard to learn how to do something if you don't see patients in a continuity fashion. And that is a strong feeling of mine, that you can see one patient there and another patient here. Unless you see what happens to a lifetime over a patient, it's hard to be able to take care of them. So we've got 140 plus nephrologists on our medical staff at Northwest Kidney Centers. Most of them are willing to see PD patients. There are literally there are less than 20 that will take on home hemo. Like there's somebody from a 7-person practice, one person sees home hemo. That has to change before home hemo is going to grow. So in terms of what to do for fellows, they have to have dedicated time that they can actually see patients in continuity. So I feel very strongly about that. And you need to make, there needs to be both a stick and a carrot in some way from an ACGME perspective. The bigger problem, though, is not training fellows on home dialysis. The bigger problem right now is attracting fellows to the field. If we can get people excited about what's happening in the field, if we can make sure that there's some innovation that can happen, as opposed to a static model that is not funded well by the government, you'll be able to attract people. I think most of us know who do clinical care that numbers of fellowship applicants are drastically down this year. There are going to be a ton of programs that don't fill. If a program fills, that's a major success. Forget about how low down you go on a list, okay? But even more of a crisis is the workforce crisis in terms of nurses and technicians. So I'm sorry to go there. It's a little bit different than your question. But there are dialysis facilities closing down right now because they can't staff them. And it's because they can't pay them, because right now with movement of healthcare workers into the hospital, you can't even staff. There are multiple areas in the country, Chicago not affected as much as most, where they can't get staff there. So just going back to wrap up, one more comment about fellows, I would make sure that fellows understand where the future is going. I think if they understand that their future livelihood is going to be impacted by the rates of home dialysis patients that they have, they're going to focus a little bit more strongly on how do I get that experience. Please, can I come with you to see how your home program works? Can I go to that national meeting? But it's not about national meetings, it's about taking care of the patients. If you grow it, they will come. So if you grow your home dialysis program, which you have done very nicely, don't get me wrong, you'll have more opportunity for your fellows to train, and that's critical. Anyways, it's a little after 1 o'clock. Come up to me if you have more questions afterwards. I'm happy to stick around for a little bit more. Seriously, thank you, everybody. I hope you feel that you can make an impact too. Get out there, advocate for your patients. Have a great day. Thanks.